didn't look at the number, but that sounds right. And there'll probably be more. Good morning, everybody. Welcome back to Grand Rounds. Glad to have you all with us today, and happy to introduce our next speaker, Dr. Christopher Schneck, who's professor in the Department of Psychiatry. He's the director of the Depression Center here at University of Colorado and has a particular interest in the management of bipolar disorder. I asked him to speak with us about the management of depression beyond the things that are familiar to us, right? We all manage depression, it's a pretty common condition. But what about some of these other things? Transcranial magnetic stimulation and so on. And so he's going to be speaking with us today about that. So Dr. Schneck went to College of Stanford and med school here, and then did his residency and fellowship at Yale. Now he's professor here, been here 28 years, I think you mentioned. Which is wonderful. So very happy to have you with us. Thank you, Dr. Schneck.
Thanks very much. Okay, thank you, and hello to folks in Zoom land. So this is a talk actually I gave last year at the American College of Physicians because they had a similar interest in understanding some of these newer treatments. These are my conflict of interest disclosures. I receive, importantly, no pharmaceutical money. It's all from either private research funding or NIMH. And just to quickly review the learning objectives, one, it's to understand what do we mean by treatment-resistant depression when we talk about what is known as TRD, and then just going through the fundamentals of each of the three major areas, new strategies, which is transcranial magnetic stimulation, ketamine and S-ketamine, and then finally psilocybin, which of course has gotten a great deal of press over the last couple of years. And what I wanted to do was start out with what I think is a pretty typical case of treatment-resistant depression. This is a 38-year-old woman who came into her primary care physician's office stating that she was not sleeping well, felt tired all the time, and was really always feeling depressed, and says that she's been depressed virtually as long as she can remember. She says that her work has not been going well because she has difficulty getting out of bed and getting going. She says she feels sad all of the time. She eats only sporadically and feels constantly exhausted. She is able to fall asleep, but then has sort of classic nocturnal awakening and then can't fall back asleep after she wakes up and feels like she sleeps only a few hours per night. And her friends have certainly noticed this and told her how much they worry about her as she seems to be losing weight and really looks sort of classically depressed. She's never been hospitalized. She's never made a suicide attempt. She has been on a lot of antidepressants, which I will detail in a second. Really no complicating medical issues, and doesn't take any other medications, and drinks only socially. She has a great fear of alcohol because her father suffered from an alcohol use disorder. So let me go through the number of antidepressant trials this woman had been on. She was first diagnosed with depression at age 21 and begun on sertraline at 100 milligrams, and gradually that was pushed up to 200 milligrams over time. She remained depressed for the next 3 years and was changed to a different SSRI, namely escitalopram at 20 milligrams. At 31, she had a difficult life circumstance in which she broke up with her boyfriend and certainly noticed that her depression worsened, and at that point was changed to an SNRI, namely duloxetine, and the dose was increased to 60 milligrams. At 32, she decided to stop medications when she moved overseas, came back a year later and found a new doctor, but still felt quite depressed, and at that point was restarted on duloxetine, and then that drug was augmented with quetiapine, the antipsychotic. A few years later, she became involved and was married. She became pregnant, but still remained quite depressed and was changed from duloxetine to bupropion. And following the birth of her child at 38, she continued on bupropion, but at that point was really wondering, is there something else that can be done besides sort of these endless medication strategies? So that is, at least at the Depression Center, where we treat a lot of patients, a fairly common history, unfortunately. Let me just briefly go through what we mean when we talk about treatment-resistant depression, and also the percentage or approximate percentage of people who are affected by it. This is, I'm going to show you the treatment algorithm from the STAR-D study. STAR-D stands for Sequent Treatment Alternatives to Relieve Depression. It was the largest NIMH study done, involved about 4,400 patients across the country, including half of the sites being primary care sites. All patients who entered into this study had non-psychotic major depression. Most were moderately depressed, and they all were put on citalopram. And I should note that when this study came out, the maximum dose of citalopram was 60 milligrams rather than 40 that it is today. So there was much more latitude in how high you could dose the drug. The point of each level was to achieve remission, so the absence of depressive symptoms. So each patient remained on citalopram for 12 to 14 weeks. If you were still depressed at that point, you got randomized into two different groups. There was a group on citalopram that stayed on citalopram and then either received supplemental bupropion or augmented with buspirone or received cognitive behavioral therapy. Or there was a group that was switched to bupropion or sertraline, so a different SSRI in that case, or an SNRI venlafaxine. And then there was a group that received only cognitive behavioral therapy. So those folks remained on those drugs for another 12 to 14 weeks. If they still were depressed and did not achieve remission, they went to the next grouping. So we had folks who then switched to mirtazapine or a tricyclic nortriptyline, or the group that originally got bupropion, sertraline, or venlafaxine then got augmented with lithium or triiodothyronine, which is really two mainstay augmentation strategies when we treat depression. And finally, if you did not get better after all of that, you got switched either to an MAOI, namely tranylcypromine, or you got put on the combination of venlafaxine and mirtazapine, which thought to have particular synergy when they are given together. So if you look at remission rates after each level, this is what you see. Off the bat, patients getting citalopram first line, about a third of them got to remission, so 28%. When you go to level 2, it was 25%. When you go to level 3, 18% achieve remission. And finally, with a very treatment refractory group, 10% of those patients achieve remission. So if you look at all those folks, about 71% in the STAR-D study achieved remission, leaving about 29% very refractory. Traditional definition of treatment-resistant depression is usually when you fail 2 or more antidepressants. So some of these folks failed as many as 4 antidepressants. And that is consistent with the general literature, which shows about 15 to 30% of patients ultimately have what we designate as treatment-refractory depression. And in many ways, I think this is not surprising when you think about mechanisms of action of our drugs. So this was from a paper that Tom Insel, who was then the NIMH director, put out, looking at different mechanisms of action. And in the green, you see depression. The blue is a point of comparison in psychiatry, are mechanisms of action of drugs for schizophrenia. And then as another point of comparison in the black are cardiovascular drugs for heart disease. So you jump ahead 60 years, the folks in cardiovascular medicine have more than 15 different mechanistically different and distinct drugs. In psychiatry, we did manage to raise the bar by 1 when we added ketamine, which largely works on glutamate. But so we have serotonin, norepinephrine, dopamine, and now glutamate, and not much happened with schizophrenia. So the idea that giving patient drug after drug after drug, an antidepressant, really you're using the same 2 to 3 different mechanisms. So when a patient fails those, it isn't necessarily that surprising that they consistently don't work for some of these patients, and they really need a different treatment strategy. So just to summarize then, about 15 to 30% of depressed patients will have treatment refractory depression ultimately. Again, nearly all of our current antidepressant strategies use the same monoaminergic mechanism. And clearly, given the burden of this disease, there is a need for alternative and more effective strategies to treat depression. So let me start with the oldest treatment, which is transcranial magnetic stimulation, and oldest meaning it goes back to 1985. And this was a treatment strategy really developed in the world of neurology for movement disorders, but has found its way into the world of psychiatry. So TMS, transcranial magnetic stimulation, it used to be called RTMS for rapid transcranial magnetic stimulation, uses rapidly alternating magnetic fields, which then can induce and stimulate nerve cells in very specific targeted areas of the brain that we think are important in the management of mood, to ultimately improve the symptoms of psychiatric illness. And TMS really now is used for several different psychiatric illnesses. It was approved for major depression in 2008, for obsessive compulsive disorder in 2018. It's an aid in smoking addiction in 2020, anxious depression in 2021, and migraine-associated pain. One of our faculty members just got a grant to look at TMS in the treatment of methamphetamine addiction. So it has a host of different strategies, all wonderfully non-invasive. And TMS takes advantage of Faraday's law. For those of you who may or may not remember Faraday's law from physics, when you use an electric coil to within an electric field, you can then induce electrical activity in the brain without the need for direct contact. And if you look at the figure of 8 coil, what you see there is you can very precisely target specific areas of the brain, not only in a point, but also in depth by varying certain parameters of the machine. So that's the way TMS works from a physics standpoint. This is a typical setup. So sitting in the chair there is Dr. Rachel Davis, who's our Vice Chair of Clinical Affairs and also is the Director of the Neuromodulation Service. And the woman standing there is Dr. Elizabeth Fenstermacher, who runs our TMS service. This is one of our 2 TMS machines. This one looks kind of like an incredibly expensive exotic hairdryer that my mother used to sit under. And there are different types of coils. So this particular machine uses what's called an H coil versus what I showed you earlier, which is a figure of 8 coil. And this shows a figure of 8 coil and really how you target typically the left dorsolateral prefrontal cortex. The way you figure out your positioning is you approximate the position where you think the motor strip is, and you start sending small magnetic impulses to stimulate what you hope is their contralateral thumb. And when you get a response for their thenar eminence, you then move the machine about 5 centimeters anterior, and each patient has a little like skull cap that you mark with a pen where you want the machine to be positioned each time you're treating them. So it looks a little funky, and each patient has their own little skull cap. They have to position it every time they come in very precisely, and we have all these markings so that the machine will be marked precisely. There are different strategies that are evolving. Very expensive strategies include using MRI imaging. We're not doing that currently, but we've just switched techniques for a different targeting strategy. So let me just show you, this is a TMS demo, of course, that I found on YouTube. This is not rapid transcranial magnetic stimulation. This was done in a lab using a figure of 8 coil. And what this woman is going to do is use single pulses of a magnetic pulse to stimulate different areas on the motor cortex, but it does show how precisely you can target different areas.
Hi, Recon. Welcome to our laboratory. Today, we're going to show you how the transcranial magnetic stimulator works. So first thing, Yoshi's going to put the magnetic coil over top of the area of my motor cortex that's responsible for the muscles of my hand and forearm. Once she's there, she's going to deliver a magnetic pulse. Oh, and you probably saw my arm twitch there. And we can also see this response over here on the oscilloscope because we've measured it using the EMG electrodes over the muscles of my hand and forearm. Now what we're going to do is move that magnetic coil over the span of my motor cortex from one side all the way over to the next. And what you'll see is muscles slowly recruited from my hand up to my elbow, shoulder, right leg. And after she switches hemispheres, we'll see some of the left leg come in and then down the muscles of my left arm. So here we go. So right hand, little bit of elbow, some shoulder and leg, still right leg, little response in my left leg there. We've switched hemispheres, more leg on the left side, left shoulder, left elbow, and left hand. Thanks for joining us.
So when we were trained on our TMS machines, we each gave each other pulses and had to do what we call motor threshold finding. So you'd get different areas of your brain stimulated. It is a pretty weird thing when you're hitting your motor strip and different areas of your body are moving involuntarily. So what, of course, we're not doing is hitting the motor strip when we give our TMS. So we're targeting deeper structures of the brain, and a typical treatment course for major depression involves giving about 3,000 pulses. And depending on your protocol, that'll vary between 18 to 30 minutes total. You give that 5 days a week, 4 to 6 weeks of treatment. And this is sort of a theoretical, typical treatment strategy that a patient would come in for. You set the machine at 10 hertz in this case. You would do 50 pulses per train. So that's 5 seconds of delivered pulsing. And then you have a rest period or intertrain interval, which varies between usually 11 and 25 seconds. And then you repeatedly do this to add up to 3,000 pulses. We do a little bit of a different protocol for our patients with shorter, with more extensive trains and shorter intertrain intervals. So our total treatment time is about 18 minutes with our machine right now. What are the most common side effects? Well, headache. You can also get a fair amount of scalp discomfort at the site of where the pulses are going in. Also, even though we're pretty precise in targeting, you can get involuntary facial twitches. I certainly experienced that when we were learning on this machine. And it takes a while to get used to, certainly, although it is amazing how well patients tolerate this treatment. You start at a lower intensity, and over time you work up, and patients really do get quite used to it. Rare but serious side effects include seizures. Now, just to give you a sense of where that seizure rate is, antidepressants have a seizure rate of about 1 in 1,000. So the fact that a TMS machine has a rate of 6 in 10,000 is lower than traditional antidepressants. Same thing, you can induce mania in vulnerable individuals with a very low 0.8%, which is no different from sham. If you look at switch conversion rates using antidepressants in patients who have bipolar disorder, it's about 15%. And then these machines are loud, so you do have to give patients hearing protection when they are getting their treatments. So how does TMS stack up in terms of other treatments we know for treatment-resistant depression? Electroconvulsive therapy is really the gold standard for treating TRD, which has best case scenario remission rates of about 48%. TMS, you're hitting about 37%. Now, I put in the SAINT protocol. SAINT was developed at Stanford. It is essentially packaging 4 weeks of treatment into 1 week. So patients get up to 10 treatments per day. It is a very intensive treatment strategy. In a preliminary study that they did, a small study, they achieved an astonishing 86% of patients going into remission who had TRD. It's really amazing for patients who have been depressed that long. SAINT right now, it is patented, and we're going to try to do a SAINT study One of the big issues, though, has to do with how do you pay for it, because you're tying up your machine for an entire day with a single patient, and insurance reimbursement has not in any way caught up with that. So SAINT as a widely public treatment is still not yet available. And then I'll get to ketamine and S-ketamine as we go on. Just some other considerations. Insurance is a big deal for this treatment. You have to have a diagnosis of treatment refractory depression, meaning you have to have failed at least 2 antidepressants. And for patients who have Medicare, they have to have had a course of psychotherapy. What exactly that means is not yet defined, but somewhere in the chart, it has to be documented that the patient has received psychotherapy. You can't use this treatment for bipolar depression. It's not covered by insurance. And for most patients, the out-of-pocket cost is going to be out of reach, $10,000 to $12,000 for a 4 to 6 week treatment. And as I said, the SAINT protocol appears very effective, but it's not clear how it would be reimbursed. So let me switch to ketamine and S-ketamine. On the left is S-ketamine, marketed as Spravato by Janssen Corporation. And on the right is a typical racemic ketamine mixture. Just to give a brief history about ketamine, it was developed by Parke Davis in 1962. That's a painting on the left of the original Parke Davis building. It is a derivative of PCP, and what was found when this was used in pre-op and post-op patients for anesthesia, that on PCP, patients became extremely agitated. So Parke Davis then looked for a derivative of PCP that could still help with pain management and anesthesia, but not make patients so agitated, and they came up with ketamine. So I think, as most of you know, it's a short-acting analgesic, anesthetic and amnestic, but without hypnotic properties. It was approved as an anesthetic by the FDA in 1970. And then really it was the Vietnam War where its utility was shown, because it was used widely in the field, because it didn't drop blood pressure, it didn't depress respiratory rates except at very high doses, and was a good pain agent, so used widely during the Vietnam War. Perhaps the guitarist Dr. Ernest may recognize his old subscription to Cream magazine. This is from 1976. It was America's only rock and roll magazine, but they had an article back then about ketamine, which they called green. And if you notice in the lower right-hand part of the magazine, this is not heroin, this is not cocaine, this is green, the perfect high, more dope inside. So corresponding with the Vietnam War was also the rise of ketamine abuse in the 70s. This is from the article in Cream. The consensus of opinion of a wide range of users is that green is essentially a non-anxiety provoking hallucinogen lasting 45 minutes, acid without the pain. So that started to increase its popularity. But it also was noted in 1975 that patients who had been depressed and had received it postoperatively did seem to be less depressed. And then in 1999, ketamine was classified by the FDA as a Schedule III drug. So its current uses and doses, it's used in pre and postoperative pain management between 0.1 and 0.35 milligrams per kilo. As a general anesthetic, for induction, higher doses up to 4.5 milligrams, and for maintenance during anesthesia, up to 0.5 milligrams per minute, and used in pediatric procedures and also in chronic pain conditions. So things were relatively quiescent on the psychiatry front until the year 2000, and this article came out. So that shows Dr. Rob Berman, who was the first author on this patient. Rob and I were classmates during residency, and he did this really notable study. It only involved 9 patients, but what they did was they gave an IV infusion of ketamine at 0.5 milligrams per kilo over 40 minutes. Each patient was his or her own control. So they got 1 week, they got ketamine, and the other week they got normal saline. And 9 patients, only 7 completed the study. They'd all been off of their medications. And what they found was really quite remarkable and unexpected for the authors, which is within 24 hours, patients noticed a really substantial change in their mood. And by 72 hours, they experienced a 14-point decrease in their depression scores. So 14 points, to give you some sense on a Hamilton, is the kind of thing we see maybe after 8 weeks of antidepressant treatments in a few patients. Most patients will not improve that much on traditional antidepressant treatment. So this was really an unexpected finding, and the signal was so strong, it led then to a lot of other studies using ketamine. Ketamine largely affects the glutamate system, but it is an exceptionally complex drug. It hits opioid systems, monoamine systems, cholinergic systems, alpha systems, affects BDNF, a whole bunch of stuff. There was a study using naloxone, which showed it actually blocked much of the antidepressant effect. And there were arguments that is it really just stimulating the opioid system, although that has since been, I think, reasonably disputed. But overall, it is not a simple drug whatsoever, and understanding why exactly it induces such a rapid antidepressant effect is still being explored. In terms of selecting patients for who should get ketamine or S-ketamine, and I'll talk about each in a minute. So typically, you do have to have failed at least 2 antidepressants. A big contraindication is the presence of psychosis or even a history of psychosis. Now, ketamine is classified as a dissociative agent, not a psychedelic, but certainly patients can have hallucinations on ketamine, and so that's why you don't want to give anybody with a history of psychosis this drug. Patients who have poorly controlled hypertension, because we often see big rises in blood pressure, particularly with IV ketamine, unstable medical illness. Obviously, if someone's a substance abuser, this is not a good drug to be giving people, and really untested in patients who are pregnant or breastfeeding. And it's really unknown whether or not, if you've failed other strategies like ECT or TMS, would you respond or not to ketamine or S-ketamine. The typical dose for ketamine, so delivered intravenously, is 0.5 milligrams up to 1 milligram, classically delivered over 40 minutes. And there really is no evidence that if you go above 1 milligram per kilogram, you're going to get any better response. And in fact, what you do see is a lot more side effects when you start increasing the dose, particularly blood pressure elevation, dissociation, and also, I would say, nausea. And I think what folks in the field agree on, that if a patient shows no response after 6 treatments, it's just not going to work. What I have found in some of my patients who have sought out ketamine treatment in the community is that despite not having a response, they continue to get treatment after treatment. And the cynical part of me says that it's because this is an out-of-pocket service, and the providers can still make a lot of money. So we stop all our treatments of S-ketamine. We're not yet doing ketamine here after 6 treatments if there's no response. One of the questions is, if you give somebody ketamine, how long does the treatment response last? In Rob Berman's study, it faded after about 2 weeks. This is from a Cochrane review in 2015. What you see there is under that column, response rate. So that's a decrease of 50% of your symptoms versus remission, absence of symptoms. And then these time points, this is at 24 hours, this is at 72 hours, 1 week, and then 2 weeks. And what you consistently see is after a single dose, you see treatment response fading between 10 and 14 days. And this has been duplicated in many, many studies. So unfortunately, this is not a lasting treatment, despite the fact it's a very rapid treatment. Some other considerations with ketamine, we really don't know the ideal frequency of dosing at this point. There doesn't seem to be any difference between 2 times a week versus 3 times a week. We just evaluated a patient yesterday in our clinic who was getting ketamine from an outside provider who's getting it 5 days a week, which I thought was ridiculous. She believes it's helping, so I couldn't really argue, but at least the evidence would point to the fact there's no difference between receiving it twice weekly to 3 times weekly. It's not clear how long patients should continue on this treatment. And we're not really sure over the long haul how safe is this treatment, although it does seem to be pretty safe when delivered in a thoughtful and sound manner. Of note, it has no indication for any psychiatric disorder because it's been a long time generic drug. So it is the brave new world when you go out into the community, because all kinds of different providers are giving this treatment for all kinds of different psychiatric conditions, which concerns me. And it is often not covered by insurance, so the typical cost out of pocket for a patient is between $250 and $500 per infusion. The most notable side effects, certainly it's a dissociative anesthetic, so you get dissociative problems with the drug. It can raise heart rate and blood pressure. Sometimes blood pressure can go up pretty high post-infusion, and a fair number of patients get pretty nauseous or will even vomit when they get IV ketamine. It also can cause inflammation of the bladder wall, and those conditions can be permanent for some patients. So I said that there's a brave new world out in the community. This is a picture I took in my old neighborhood, and this was literally a candy store I used to take my kids to. It is now a ketamine shop, the Innovative Ketamine Therapy Group. So I did some exploring online. These are the kind of prices that you can expect if you go in there. You can get the 6 infusion package for $3,600, or the booster infusion package for $1,200. Another very popular website and treatment is through MindBloom. What MindBloom does, this is all virtual online. They will assess you, I guess I put assess in quotes, and then send you a blister pack of ketamine troches. I'm not quite sure the dose nor how they determine that dose, but they send it to your home, and this is their price list. They call it a Bloom box. And you get 2 clinical consults, $193 per session. I find this exceptionally concerning because ketamine, in my view, is not a drug to be taken lightly. And in fact, the FDA in October of last year came out with this warning about compounded ketamine products, including oral formulations. Ketamine undergoes tremendous first-pass metabolism, which is why it's typically given IV. And so the dosing when giving it orally is really all over the place and not well explored. So key points from the FDA warning was that it's, again, not approved for any psychiatric disorder. Compounded drugs are not FDA approved. And use of compounded ketamine products without monitoring by a healthcare provider puts patients at risk for serious adverse events. Known safety concerns include abuse, misuse, psychiatric events, increases in blood pressure, respiratory depression, and lower urinary tract and bladder symptoms. I certainly know, though, a lot of my patients have pursued these types of treatments, understandably, when they feel pretty desperate for some other treatment strategy for their depression and can't readily find a local ketamine provider. So that's the story of IV ketamine. Now, in 2019, Janssen came out with a nasal spray, S-ketamine, so the S enantiomer of ketamine, which is the active enantiomer, which is marketed as the drug called Spravato. It's a Schedule III drug. And this is a Spravato cartridge. Each cartridge is 28 milligrams. It has 2 FDA indications currently. One is for treatment-resistant depression, again, with the having failed 2 antidepressants. The other is depression with acute suicidality. So one of the things that ketamine has shown is that it can reverse suicidal thinking within 24 to 72 hours. Because it is an abusable drug, the FDA put forth the risk evaluation and mitigation strategy. So each clinic and each pharmacy that handles Spravato has to go through a test. So we have a S-ketamine clinic here, and we had to be REMS certified in order to use this drug. The big thing about using Spravato is that patients have to do it in your clinic and have to be observed for 2 full hours after they self-administer the drug. They have to be taking an antidepressant as well. If you're trying to do this out of pocket, it's exceptionally expensive and out of reach for most patients. in the initial month's worth of therapy out of pocket would run you almost $77,000 just for the drug itself, and that doesn't include any of the physician or clinic time. So this is what each cartridge looks like. You hand the cartridge to the patient, they stick it up their nose. It's got two little clicks, so to deliver precise dosing. And most patients use 3 cartridges. Each cartridge is 28 milligrams. So minimum, you need 2 cartridges, and then maximum, you can give them 3 cartridges, and they rest for 5 minutes between each dose delivery. You do a 4-week induction phase, the patient coming in twice a week, and then you assess how well the patient is responding. And again, for us, if they don't respond, then we will stop treatment. You then can start to spread out the dosing every 1 to 2 weeks. But similar to ketamine, the effects of this drug just don't appear to be long lasting. And so in our clinic, we have run into this problem, which is we can't accept new patients right now because we've gotten clogged up with just having our same patients coming in week after week after week to sustain their antidepressant response. As I said, you have to watch them for 2 hours post-insufflation. You check their vitals. We're always looking for hypertension and also dissociation. They can't drive themselves to and from the clinic. They have to either be accompanied by somebody, or they can do an Uber if they want. So how does S-ketamine and ketamine stack up in the world of treatment-resistant depression for remission? So there's ECT, there's TMS. Ketamine, maybe 31% of patients with TRD are achieving remission. S-ketamine, 38%. That's not statistically significant. I just took numbers that I had found as a point of comparison. In fact, there's some evidence ketamine probably provides a more robust overall antidepressant response. There has been a couple studies trying to broadly look at which drug is better. As best we can tell, they probably end up at the same endpoint, but ketamine may get you there a little faster in terms of antidepressant response. The advantage of ketamine is you can change the dosing depending on a patient's response and body weight, whereas S-ketamine, you're stuck at a maximum of 84 milligrams because that's what the FDA says is the max dose. So where does ketamine and S-ketamine fit in a treatment algorithm for treating severely depressed patients? I think it looks better than adding an antipsychotic, certainly, but there have been no head-to-head trials. Where should it fit in with TMS or ECT? We really don't know yet, but we have a lot of patients who are very interested in trying ketamine and S-ketamine. In the Canadian depression guidelines, mood and anxiety depression guidelines, they rank it as 3rd line in use of treatment-resistant depression, and the Canadian guidelines really are the best things going right now. Not used in pediatric patients thus far, not used in geriatric patients, and not used in bipolar depression, where we really need some other strong treatments. So, and then there's the insurance coverage. I'm part of a group of the National Network of Depression Centers. I'm part of a ketamine task group. We just came out with this paper. It's being published in February, arguing the need for insurance companies to cover IV ketamine, which is far, far cheaper than having these patients get ECT or be hospitalized, for instance. Whether or not this paper moves the needle, I don't know, but we certainly felt we needed to argue that insurance really does need to cover this stuff. So just to conclude about ketamine and S-ketamine, you can apparently rapidly change people's mood and improve their depression within days to a few days or a week. So that is really an important finding. IV ketamine certainly works, but the effects just don't seem to last longer than 10 to 14 days. We have evidence that S-ketamine works for relapse prevention, but that's because Janssen did those studies up to a year, but patients continued to get dosed. But it does seem to work for a year without untoward side effects or a fade in treatment response. So, yeah. Alcohol use Yeah, so the question was about substance use disorders and using ketamine. It's tricky, I would say, because, for instance, in Colorado, of course, we have so many marijuana users, and can you give someone who uses marijuana chronically ketamine or S-ketamine? I think if it is not trending into the misuse disorder, the answer is yes, and we have to make these decisions all the time. I think it's an unexplored world right now. There have been no studies really looking at if you're giving someone ketamine or S-ketamine, in fact, does their substance use worsen? I think providers are pretty cautious who are giving this drug right now, given liability issues with use and misuse. So I wouldn't say no, but I think it depends on the drug and the circumstance, honestly. Yeah. On ketamine IV, no, because there's no FDA indication. S-ketamine, they have to be on an antidepressant in order for insurance to meet criteria that insurance would pay. Yeah. So last, let me turn to psilocybin, which is in the news quite a bit. On the right, that's a picture of indocin, which was synthesized by Sandoz Company in 1960. So psilocybin itself is present in more than 200 mushroom species, and it is in the category of classic psychedelics, similar to LSD and mescaline. And that is distinct from ketamine, which is a dissociative agent. In the press, ketamine often gets lumped in with things like LSD and psilocybin, but they are different agents. And there's also been a rise in ketamine-assisted psychotherapy, which really, at this point, I think there is no evidence that ketamine-assisted psychotherapy would be any better or worse than psychotherapy, whereas with classic psychedelics, there is a difference, I think. Psilocybin gets metabolized to psilocin, which is the active component, and it's a 5-HT2 agonist, and that's really what produces psychedelic effects. It's actually a fairly safe drug physiologically. Really, the problems much more are psychological with this drug. And namely, given in sort of unmonitored settings, it can cause anxiety, fear, and confusion that ultimately can lead to dangerous behaviors. Just to briefly go through the history of psychedelic research, of course, psychedelics have been used during ceremonies and healing for more than 3,000 years, as best we can tell. LSD was synthesized in 1943, Dr. Abby Hoffman, and then Sandoz isolated psilocybin and synthesized it in 1959. And during that time, there was an incredible interest among psychiatry and other researchers in the effects of these drugs, and more than 1,000 clinical papers were published. However, in 1970, the Controlled Substances Act seriously limited the availability and access to psilocybin, and that graph that you see shows the number of academic papers published about LSD and psilocybin peaking in 1970, and then this rapid drop-off until about 2010, which I'll talk more about when papers and interest began to be renewed. So it really stifled any further academic work looking at these compounds. However, in 2008, there was a report about the use of psilocybin in patients with life-threatening cancers facing end-of-life anxieties, which showed an incredibly positive effect after a single dose of psilocybin. And we then had reports of the use of psychedelics, particularly psilocybin, in treating addiction. And in 2018, MDMA and psilocybin were designated as breakthrough therapies by the FDA, which did increase the ability for researchers to do studies with them. Although I can tell you, as someone who's working on a study of psilocybin right now, there are a lot of FDA hoops to jump through when you're trying to use a Schedule I drug therapeutically. So why might these drugs work? Well, I said it's really mediated through serotonin 5-HT2A agonism, and it may be particularly effective in patients who have what we call internalizing disorders. So lots of ruminations, repetitive thinking, guilt, self-critical internal narratives. It may work by resetting what's called the default mode network, which is sort of the underlying baseline electrical activity of the brain. My own interest in psilocybin evolved when I treated a man for about 5 years for depression. I tried everything I could to get this guy better. I got him maybe 50% better. And then one day he walked into my office looking amazing and finally and reluctantly admitted to me that he had used psilocybin in a very therapeutic setting. Somebody who was really providing, I think, good psilocybin treatment. And his depression was just unbelievably better and stayed that way for 18 months. And when his depression recurred, he responded much better to antidepressants. And that's when I started investigating psilocybin. Had I not seen it with my own eyes, I'm not sure I would have been as interested. So this idea that it disrupts entrenched neural networks may be underlying its mechanism. I'm not an imaging guy, but there are several studies showing that when patients get psilocybin, it changes core features of their brain activation. These are studies done by Robin Carhart-Harris showing changes in what's called the default mode network corresponding to treatment response. So psilocybin is being used in a number of different areas, depression, of course, cancer-related existential anxiety, tobacco use disorders, alcohol use disorders, and OCD. And you can see all of these things have this sort of entrenched thinking notion around them. And the way most practitioners are using psilocybin when it comes to psychedelic-assisted psychotherapy, there is a preparatory session that occurs a day or two before receiving the drug. When you talk to the patient about expectations, their concerns, what they hope for, they get treatment where they will take the drug and sit with 2 therapists for about 6 to 8 hours while they are tripping. And then the following day, do an integration session where they talk about the experiences they've had. Most patients find it pretty enlightening, and you try to integrate that experience into their core self. Just a quick word about microdosing. There's a lot of press about microdosing. This is, I think, the best study that's been done trying to see, does microdosing work? And just to give you the real short story here, patients were blinded to their treatment and received either 1 milligram of psilocybin or placebo. And in every instance of these measures, what they believed they were getting completely mediated the response. So if they thought they were getting placebo, even if they got active drug, it didn't work. If they thought they were getting active drug, even if they were getting placebo, it worked. So it's helpful. I don't think microdosing works, at least based on this study, and it's I think a really smart study. The second part is that we use 1 milligram as our placebo dose in our study that we're doing, based on the findings from some of this work. This is a quick summary slide of the current studies in depression, starting out with small n's. And the short story and takeaway from this slide is, number one, 25 milligrams of psilocybin does seem to be the dose you need. There was a study comparing it with 10 milligrams. 10 milligrams didn't work. So there is a clear dose response curve to this drug. In all of these studies, psilocybin produced a robust and long-lasting effect, whether it was in major depression, treatment-resistant depression, or anxiety and depression and life-threatening cancers. The most recent study that just came out last year by Charles Raison from Wisconsin, they used 25 milligrams of psilocybin or 100 milligrams of niacin, which causes flushing and gives you the feeling you're on something as a comparator. This was a double-blind study showing, again, sustained reduction of depressive symptoms and functional disability over 6 weeks. So it is a treatment that really seems to work in many patients. Conclusions from psilocybin: with screening and preparation, the risk-benefit ratio appears very favorable. There does seem to be a dose-response curve with this drug. It does appear that rapid and sustained antidepressant effects are quite promising. We don't really know what guiding or psychotherapy should look like. There's lots of guesses and people are trying different strategies. I think something that's really important is the recognition of how vulnerable patients are, that when they take this drug, they are really out of it. And it's why you need two therapists in a room, not one, because you do worry patients could potentially be taken advantage of. So overall, in terms of future considerations, these are really new and promising treatments for treatment-resistant depression. Rapid antidepressant response does appear possible, at least with ketamine and psilocybin. Lots and lots of questions, however. Where do these fit in our algorithm? Should patients, in fact, go on some of these treatments first rather than antidepressants? The more experience we have with these treatments, the better we'll understand what are the long-term effects of the treatments, what are the best patients to select for each treatment, and what kind of psychosocial or psychotherapy treatment should be given with some of these treatments. So many, many questions. What services do we currently have here at the university and through the department? We do have an ECT service, which started last July, which I'm incredibly thankful for. It was embarrassing to have a university without an ECT service. And this is how you can refer patients to that service. We have a very good TMS service right now run by Elizabeth Fenstermacher. S-ketamine, unfortunately, this is a service we began last year. We have gotten so clogged up with patients and a waiting list. We're not taking referrals currently. I'm hoping to get an IV ketamine clinic maybe in the next year, if possible. And then two psilocybin studies. Stacy Fisher, who's an oncology doc, she's currently enrolling for the study, 100 patients. She's enrolled 12, I think. She's doing it in our space in the Anschutz Health Science Building. Still looking for patients who have stage 3 or 4 cancer and have existential distress. And then Andy Novick is heading up our study looking at anhedonia in treatment-resistant depression. We are hoping to enroll maybe in the next 2 months for this study. We're looking at, I think, 25 patients we're going to enroll. There is an open label part of this study. It's a blinded study, but it does have an open label aspect to help recruitment. So patients ultimately will end up on psilocybin. And that is what I have. So thanks very much. Looks like there's a few minutes for questions. Sure.
The S-ketamine clinic, how often are you having adverse effects in that 2-hour period?
Yeah.
Like some more people are using it recreationally, well tolerated. Like, how much of a need is there?
Yeah. So the question is about how often are we getting adverse effects in the S-ketamine clinic? You know, it has been really well tolerated. We did have a patient vomit last week, in fact. But that's been a rarity. Patients get kind of spacey. They complain a lot about the taste they get in their mouth. We've got mints and things like that. I've been impressed how well tolerated it's been. So, and it's also interesting that the patients, we do 4 patients at a time is what we can do right now. They're all in the 2-hour waiting period because they get kind of bored. They're all hanging out together. And honestly, there's a sort of group therapy aspect of it, which has been really interesting to observe, but thus far quite well tolerated. Well, one thing that Janssen is taking data on, and I am hoping for, is that they lower this 2-hour observation period. It's very problematic, and you can imagine financially, you're having to pay people to observe these folks. You're not getting reimbursed for it. And what we're seeing is patients look pretty good after about 45 minutes. Yeah. Yes? So the question is, if you get a response from TMS, how long is it good for? It's a really good question. Most of these patients will stay on their antidepressants. There does seem to be some durability of effect, but we've had patients come back within, let's say, 6 months to a year saying that they're getting depressed again, and we will do another bout of TMS. So the ability of TMS to really induce long-term changes is sort of unknown right now. Yeah. Dr. Ernest.
So my question is the cost or projected cost of the psilocybin.
Yes.
On protocolized, right now the cost would be a guess, but you have an estimate of that, how much does it cost the drug versus?
Yeah. Yeah, the question is around cost of psilocybin, because you have to pay 2 therapists to sit with a patient for 8 hours. You have to have a prep session the day before. You have to have a integration session the day after. And the drug itself, now there are many companies racing into the psilocybin space. One of the questions, and we thought we were going to pursue this question, and it ultimately would relate to cost, is do you have to have the psychedelic effect to induce antidepressant changes? And you can block psychedelic effect using particular drugs that block 5-HT2A receptors. If you didn't have a psychedelic effect, you could take it at home, or you could, dispense it and the patient could take it at home. I do think the costs are going to be quite high between the drug itself and all of the difficulties in getting a Schedule I drug to market, and then the therapy costs. It's a good question. I really have no idea, other than I expect it will be costly. Yeah. Yes, Dr. Coombs. Is there a potential for abuse or dependence with microdosing? It doesn't seem that way. I have some patients who have been microdosing a long time. They believe it works, and that is a core component of it working. And they seem to go about their lives pretty well. Microdosing, I just don't think it does very much. So I don't think so, but that is based on exceptionally limited experience. Yeah, Mark.
Comparison of the resources. So you treat once with psilocybin for say 18 months,
Yeah.
6 therapy days in there versus all of the monitoring.
Yeah, so in terms of resources, ultimately you would think it would be cost effective, right? I look at my patient, he had a single dose and was good for 18 months. And most of these studies, they'll go out 6 months, and these patients are really doing pretty well. So you could really argue from a health economics perspective, it is well worth it to have this upfront cost. But if you get someone who has that good of a response, wow, with virtually no side effects later versus, antidepressants, we all know all the kinds of side effects you run into with those drugs. So, yeah.
One more question.
Yeah.
So unrelated, can you comment on
Lyrica for depression. Lyrica we really use for anxiety, and I don't know of any studies using Lyrica as an antidepressant. There may be really small pilot trials, but mechanistically, there's nothing, at least as I think about it, that would suggest it should work. If it's relieving pain or anxiety, and that ultimately is leading to an antidepressant response, that could be another story. Yeah. Okay. Well, thanks a lot, folks.